A very good afternoon to all of you. As we wait for more people to join us, and some have joined online on the YouTube channel, it gives me great pleasure of announcing the topic of discussion today. We have a world-renowned speaker with us, Dr. Yogesh Shah, who is the Medical Director of Broadlawns Memory Center, USA. He has been to India on several occasions, and today he's going to be talking to us about a very cutting-edge, science on the role of biomarkers of different kinds in the diagnosis of dementia and its early detection. Because we know we are standing at a kind of watershed movement where there are therapies on the anvil which have come, in the US. And will eventually arrive here and would require the biomarker classification of Alzheimer's disease. So today's discussion is going to start with his talk, followed by a panel discussion. And we have very august panelists. We have Mrs. Renu Vora, who is currently the president of the Alzheimer's Related Disorders Society of India. And she represents ADI in India, which is Alzheimer's Disease International in India. We have Mrs. Veena Sachdeva, who is the Vice President of the ARDSI Delhi chapter. And we have Dr. Madhvi Tripathi, who is also involved in the nuclear imaging, particularly the tau imaging as well as FDG, which we have for dementias at our center. And hopefully, she's very hopeful that we would be getting the amyloid imaging in the next 1 year. And to tie it all together, we have Dr. Annu Gupta, who is going to introduce the speaker and also fire questions to the panelists. And I am, of course, Professor Manjari. I'm keenly interested in dementia and run the Cognitive Disorders Clinic. I'm also the president of the Alzheimer's Disease Related Society of India, Delhi chapter. Anu? Please take over.
Thank you, ma'am. So it is my immense pleasure and my proud privilege to introduce our distinguished visiting expert for today, Dr. Yogesh Shah. He is the medical director of Broadlawns Memory Center, Iowa, United States, and is a board-certified physician in geriatrics and family medicine. Dr. Shah completed his medical school from SGS Medical College, Mumbai, followed by graduation from Des Moines University, Iowa. He did his fellowship in geriatrics from the Mayo Clinic, Rochester. He was the chief medical officer and vice president of medical affairs for Broadlawns Medical Center during the COVID pandemic. And he has served as the associate dean of global health at Des Moines University and is the founding physician for the Des Moines Memory Clinic. He is also an Alzheimer's Association advocate and has a passion for prevention and risk reduction of Alzheimer's disease. He is the recipient of many awards and accolades, including the Outstanding Leadership Award by the Alzheimer's Prevention Foundation in 2000. He currently serves on the Iowa Alzheimer's Disease and Related Dementia Coalition. So in today's talk, Dr. Shah will be talking about the role of biomarkers in early detection of Alzheimer's disease. I welcome Sir to start his talk.
Thank you, Dr. Manjari Tripathi, Dr. Gupta for inviting me, and thank you, Dr. the ARDC for invitation also. So what I like to do, this is a real hopeful time, very exciting time for the field of dementia, because there's going to be a paradigm shift. The paradigm shift is coming, that will be moving from clinical diagnosis to biomarker-based diagnosis. And because of that, we'll be also moving from middle to late dementia diagnosis to very early detection. So that's what I'd like to share with you. What's the advantage of early detection? Why do early detection? What is the science behind prevention? I just heard that there's some research going on about yoga and prevention of MCI. So we'll talk about that also. And hopefully I take lots of questions after the talk is done and during the panel session. So feel free to write your questions, ask your questions, keep it in mind, and we'll have time to ask and cover a lot of things. This is what I've been doing, as you heard from Dr. Gupta. I train at Mayo in Rochester in USA with focus on early detection with mild cognitive impairment or MCI, and have been doing this for last 20 plus years about how we can do the early detection. So this is not because of me, it's just in the background. So Phil, the topics I'll like to cover is what is MCI, what is early detection, what are the workup, or what are the biomarkers. There's a lot of other disease we can cover, other types of dementias we can cover, Lewy body dementia, frontotemporal, depending on the questions. But this is the start we'll like to do, and then focus on the other things. Let me start with this. This dementia is not a normal part of aging. So yes, it's common as we age. And as you might know, this was the study came out of Lassie Dead, which is the long study of aging in India, where unfortunately the number is going to go up. Currently in India, it's 7.4% of people over 60 have it. And at this is 2 years ago, there are 8.89 million Indians have dementia. And unfortunately, it's more common in female and more common in rural India compared to the urban area. And we'll talk about the reasons why. So let's go through the spectrum, and this is more applies to Alzheimer's disease, doesn't apply to all the different types of dementias, but more for Alzheimer's. There is a pre-condition, pre-Alzheimer disease, where there's no clinical symptoms, but is found through the biomarkers, what we'll talk about. Then, after many years of that, and if nothing gets done, comes the mild cognitive impairment or MCI due to Alzheimer's disease. And then, if nothing gets done during that time, then comes the actual dementia of Alzheimer's disease, early, moderate, and severe. And then the difference between MCI, mild cognitive impairment, and Alzheimer's disease dementia part is where in MCI there is a cognitive decline, it's declining the functionality, but patient is able to function independently. So there is independence maintained, and by independence we mean that patient is able to cook. If they are driving, then they can drive. If they're doing their checkbooks or finance or doing their bills, they can still do that. While in dementia, some of the functionality is lost. So the main difference between MCI, mild cognitive impairment, and any type of dementia is the loss of independence or functionality. Is everything technology good? Okay. So let's talk about the topic of interest for us, what biomarkers. By the time, and this is the graph, it goes through the preclinical, the MCI, and dementia, and goes through the current line is the clinical diagnosis of dementia or MCI. And by the time that gets done, usually it's either in moderate to late stages of dementia, unfortunately. But lot of things have happened to the brain lot of years prior to that, and luckily we have the neuropathologist and neuroanatomist here. So the area which shows is the healthy brain, where the brain, the amount of neurons, the brain size is all good, while on the other side is the brain with people with Alzheimer's disease, where there are plaques, and then we'll talk about the plaque, and there are tangles. And those are the two reasons the brain cell starts becoming small. Those plaques are the one which are because of the lot of amyloid in the system, and tangles are the one because of tau. So those are the two proteins, two names we'll be hearing frequently, amyloid and tau. And those are the causes of why the brain cells starts becoming smaller and the synapse starts losing. This is a very busy slide, but I'll go through it detail because this is the reason we're going to talk about what happens to the brain. So and by the time clinical diagnosis happens, a lot of things have happened to the brain 18 to 20 years prior. So this graph shows what happens to the brain, just if you were to consider cholesterol. By the time cholesterol is high, doesn't mean that somebody is going to get heart attack. But if nothing gets done and cholesterol is risen for 18, 20 years, then the plaque in the coronary vessels, similar things happen to the brain. The amyloid is formed, and after amyloid, there is a tau, the second protein, which then causes the change in the brain anatomy and which causes the memory loss. So let me put through in more time perspective, and this slide gets even more detail to show what and how we can pick up the different proteins, when and how we can pick up the amyloid. CSF, the cerebrospinal fluid through lumbar puncture, is one of the first one to show the amyloid changes, the amyloid 42 changes, even before the amyloid PET scan. So that's the, I think, question we can talk about during panel time, that CSF is more sensitive by X number of years. So by putting the timeline on this graph, I'll go through each one. By the time somebody is diagnosed with clinical diagnosis of dementia, time 0, let's say today, 18 to 20 years prior to that, the brain is starting to collect this extra amyloid and less is coming out in the CSF. So less amount of amyloid in the CSF means that the brain is storing, and this will become the plaque. So CSF amyloid 42 level will be starting to go down 18 to 20 years prior. After about few years after that, the amyloid PET scan, which I just realized is not available yet here because of the cost, which I can do it in the US, becomes positive. So first is the CSF, lumbar puncture, and we'll talk about the plasma in a minute. Then comes the amyloid PET scan. After that, after amyloid is collected over time, then the tau starts getting collected. And then tau can be selected and seen in the CSF or lumbar puncture, cerebrospinal fluid. After a few years of that, the amyloid PET scan, which you have capacity to do here, becomes positive. So if amyloid PET scan is positive, that means that clinical changes will happen in very likely in 5 to 7 years. If somebody is asymptomatic, but if amyloid PET scan is positive, that person has still 5 to 7 years window to do yoga, to do all the prevention we'll talk about. So this is the tentative and well proven now, the timeline of what happens with biomarkers at different stages of life. Just to repeat, because there'll be a lot of focus and talk about this biomarker staging. The time 0 is the clinical stage of dementia. 3 to 4 years prior to that happens the mild cognitive impairment, or MCI. Prior to that happens is the positive changes in the brain through anatomy, through MRI, through FDG PET scan. And 18 years all the way back comes the actual amyloid pathology. This is all about Alzeimer's. As you know, in different dementia, Lewy body would have more of alpha-synucleinopathy. The frontotemporal dementia would have different pathology, but this is more applies to amyloid pathology. keep your questions in mind, because as I said, this is a very relatively new field. Even in US, most medical students, residents, and I see some of you are resident here, or practicing neurologists or physicians are not still aware. It's a very cutting edge field where things are moving very fast. The reason, I'll tell you what happened personally to me. I was the chief medical officer of the hospital, as you mentioned. But when I realized the field is moving very fast, I gave up my administrative role to be part of the field, not to miss out. Because just in even since July of last year, I came back to actual practice again. Even in this time, there are a lot of new tests coming out every 2 months. Mayo had a test about plasma NFLC. The lab core came out with ATN, and I'll mention about that. Thank you. So if you've not heard of some of these terms or some of this, don't feel bad about it. You are still be proud that you are part of a top part of symposium where this is getting talked about or discussed. So, and what the future very likely will be, instead of giving just pure clinical diagnosis, and this is already been talked about, that diagnosis should be based on biomarkers. So the diagnosis will become A, T, and N based. Amyloid positive, amyloid negative, T positive, T negative, or neurodegeneration positive or negative. So that's going to be the future in few years. Already been discussed, very likely. So some of this, sorry for the small print, but what might be available, as you know, it varies. But luckily, AIIMS, from what I heard in short time, lot of good things are happening here. So PET scans, both amyloid and tau, will hopefully become manageable, at least in the research bigger places. Tau you already have. Amyloid will come with cost going down. The second currently is the CSF, which you are doing it here in your lumbar puncture CSF to check for p tau over 42 ratio. That's already happening, which we can do there also US. But the most important part, I feel, and the game changer will be when the biomarkers happen through blood, the blood-based biomarkers. And very likely that will be coming soon. So the way blood-based biomarkers can be checked will be the checking for both plasma amyloid 42 and 40 ratio, the plasma T tau ratio. That's the second protein we talked about, which causes the brain cell to actually damage. And then also plasma NFLC, the neurofilament light chain, which is the degeneration. When the brain cells start dying, that's where this gets secreted. And there's another called plasma GF AP, which is going to be coming out to see what is the synaptic functionality also. So that's the future of biomarkers and future of blood, where the need to wait till the actual clinical symptoms happening as a mild or moderate. Instead of that, we'll be doing the blood test much earlier, especially if somebody has a family history, somebody is worried about, or somebody in the mild cognitive impairment stage. We can do the actual testing to prove that yes, there is a protein, amyloid or tau or neurofilaments. So that will be happening. I'm already practicing that in my practice, that a lot of young people in their 60s, for US it's young, coming to check for how their ATN biomarkers are. So just example, I had a PhD supervisor of a big school system, very worried because even the functionality was good, but started multitasking became difficult for him, difficult to remember the common places where he was going. Check the blood first. ATN was positive. Check the LP, that was positive. Now he's on the treatment for anti-amyloid treatment, which is available in the US. It's called Lecanemab, which takes away, which dissolves this plaque, and hopefully by doing that, slows down the cognitive decline. So that we'll talk more during the panel about how Leqembi works, how am I using that for my patients. And why does it matter? Why do we have to do all these biomarkers? Renuji asked that question before I give this talk, started talk, because now there is a very strong proof that up to 40% of dementias, up to 40% of MCI can be prevented to become dementia or reversed or slowed down by appropriate prevention. And I'll share what that means. So up to 40% of all dementias, MCI and other dementias, can be slowed down or reversed by appropriate measures. And by early detection, we can improve the quality of life. So that's the other function. So what are those 12, what are the factors for prevention? This came out from a very good study by Lancet. You all probably are familiar with Lancet, a medical journal used in our medicine very frequently. We quote that. So Lancet did 2 studies, came out with 2 big topics on dementia. The first one was in 2018, and then they followed by another call, this one 2020, about what are the 12 factors which can prevent or slow down dementia by 40%. And they did this through lots of international well studied articles, 675 of them, and 25 experts around the world came up with this topic about what's the science behind prevention. And the reason for this prevention is it does work because of 3 factors. The brain is our neuroplastic, and I hope we don't teach anymore. When I went to medical school in Mumbai, Bombay that time, GS Medical School, we were under the impression and taught that by the time brain cell is formed by 6 years, that's what you have, and you can never add any extra brain cells. But that topic is now not true anymore. That brain is a neuroplasticity, the plastic meaning that hopefully all the way till people died, 80, 90, the brains can form new brain cells, neurogenesis. Along with that also comes synaptogenesis. Brain forms new cells and new connections, doing yoga, listening to good music, learning some new language, doing something with the hand, learning musical instrument. Multiple things can cause this neuroplasticity to help us out. The other topic is, that's part of the prevention also, cognitive reserve, meaning that amount of time, energy we put to have our brain cells early on in our life, the childhood we talked about, education, the better the brain can preserve as we age. So hopefully all the young physicians in the group here, the younger you do take care of your brain through multiple factors I'll mention, the chance of dementia goes down significantly. Cognitive reserve, just like financial reserve. If you put early on and save money now, when you want to retire, when you're 65 or 60, there'll be enough money left. Same concept applies to have enough cognitive reserve early on. And the third topic, hopefully you study in the medical school, is epigenetics. That even though we might have genes for dementia, there's a gene called ApoE4 and 4 is, even if there's a gene for dementia, chances of Alzeimer's, by doing physical lifestyle, by exercising, by cognitive health, that epigenetics, the gene switch can be controlled. So that's the concept of epigenetics. That just because I have gene for cancer or dementia doesn't mean I have to get it. Through lifestyle modification, we can control that switch becoming on or off. So that's the concept of, so between neuroplasticity, cognitive reserve, and epigenetics comes the 12 factors which might help us to prevent dementia by 40%, 12 factors. And they are divided into 3 stages of life: early, middle and late life. So early on, the more we invest in education, the higher the education, the better the chance of brain to grow more cells. So the importance of finishing high school, the importance of finishing college, and even lifelong learning. That has connection. And what Lancet, the brilliant thing Lancet did, Dr. Tripathi, I enjoy because it even gave percentage. So seven percentage of this 40% comes because of finishing high school education. Comes the midlife, that those who have hearing loss and get the hearing aids, they can reduce their chance of dementia by 8%. So hearing loss by itself is not a problem, but not getting it fixed by hearing aids, we can reduce our chance by 8%. Because of the connection, there's many reasons for that. One of the reasons being anatomical connect nearby. Second is called cognitive reserve, that if I have hearing loss, I spend more energy to hear rather than remember what I heard. The other part, more common with people who are football players, soccer player, is a traumatic brain injury. That those who get frequent traumatic brain injury during their early childhood, during their younger age, they have 3% higher chance of getting dementia, which we have seen in US in the football players. That a lot of young football players in their 45, 50 tend to get dementia. Unfortunately, happens to boxers and many sports, contact sports. Hypertension. So this is a clinically very meaningful. Those of you or us who have uncontrolled blood pressure, bringing the pressure normalizing is one of the best thing we can do to reduce chance of dementia. So let me repeat that. The treatment for anti-hypertension is probably the best treatment for dementia prevention. So controlling the number of blood pressure is good for the heart, good for the kidney, but also good for the brain. The other things in late life, and I'll not go into a lot of details of each one, but not smoking has reduction of dementia by 5%. Apart from cancer prevention, apart from heart disease and lung and others, dementia by itself is 5% reduction of those who don't smoke. Depression, untreated depression, luckily we don't have to worry too much about depression in India. It's coming, it's there, but our social structure helps us. But during pandemic, I saw rise of depression, anxiety, loneliness, and following that brain fogginess in the US because of isolation. So that the depression and social isolation in my mind goes hand in hand. That social isolation is 4% higher chance. When I ask my patients that bring someone you love or somebody who lives with, and if they come alone, that's already a red flag for me, that there's a significant higher chance of that person becoming, if they don't have dementia, very likely they'll become one. Because social
enrichment, especially in this kind of population, in the senior citizens, super seniors. So more interactions, whether with own family members, whether with a group of youngsters, that helps.
Great question. So the comment was, those who didn't hear that, yes, social interaction is very important. You're right. In US, the CDC compares social isolation, the bad effects of social isolation as smoking 12 cigarettes per day. So if I'm socially isolated, that effect of me over time becomes as if I'm smoking 12 cigarettes per day. Unfortunately, and we were talking to some of over here, that with social media, I fear that teenagers and the young people feel they are socially connected, but that's not the social connection. It has to be meaningful, face to face in a small group, drinking chai, having coffee, and being connected to that small group of people.
model studies, when we have the environment and the social enrichment, that is what we call, and then we follow these.
Great point. So yes, again, even in animal models, this has shown that we'll love to. I'd love to talk more about this with you. And no, love to talk more. So as you can see, a lot of up to controlling these 12 factors, and not all 12 might apply to all of us, but even select factors out of this. If I'm socially isolated, if I'm smoking, if I'm depressed, just solving those three things, I'm reducing by chance by 12 to 15%. So the importance of, and we'll discuss during the panel, why detect early through biomarkers? Because by detecting early, and if I'm doing some of this stuff, the things, and if I can reverse my life, change my life, I'm reducing dementia by 40%. And this is not just hopes, this is all science. This is Lancet talking, the biomarkers are well proven, and I apply in my patients every day. So, and what happens, which we unfortunately see, that if dementia doesn't get detected early, lot of things happen. Lot of things like, and unfortunately, a friend of mine in Mumbai, 71, no diagnosis of dementia, but bought a life insurance for more than crore rupees, and he had no money. So now the bank is after him, and the families are after, like, so financial mistakes can happen because the memory, the judgment, the executive function is lost. Those who are driving with dementia, early dementia, they can still drive, but accidents happen. So multiple ways things can go wrong. So let me stop here. I think we should entertain some questions. But just to finish the talk, this part, and so that way we all are on the same page, that dementia is a broad umbrella term under which comes the different types of symptoms, Alzheimer's being the most common form of dementia. Then comes the vascular dementia because of stroke, because of uncontrolled diabetes, uncontrolled hypertension. Comes frontotemporal dementia. Those of you who know the American actor Bruce Willis, that's what he has, the frontotemporal dementia, or FTD. And then Lewy body dementia, what Robin Williams said it. So those are the different types of dementia, and dementia being the umbrella term where there is enough decline, enough cognitive decline, which is now hampering my independence in some form. So Dr. Tripathi, with time, I'll stop here, take questions, and then we can have more. You made a very good comments about social importance of social data.
There are countries, like I know of some, at least in the Netherlands, where older people are put in with very young children, and there's a need and adapter kind of a fit.
Yeah, no, agree. So the social model helps. Actually, I visited that village, and I've been to Amsterdam and outside of Amsterdam. The connectivity between nursing home and daycare has helped. Yes, agree with you. Thank you.
You can continue with you have
Yeah.
you can finish the thing. Then we can
Oh, I got a lot, but I thought I think might be worth it. But I can talk.
do the biomarker part of it, and then we can do the panel.
Okay, sure. So let me talk about the quickly on the non-reversible part, and talk about the importance of biomarkers. So these are the non-reversible we talk about so far: the Alzheimer's, the vascular, frontotemporal. Oh, thank you for your comments.
And we'll do something.
Please, yeah, that's very meaningful. Social connection, yes. And let me, I think I'll stop here. The science of biomarker is now coming to all types of different dementias, meaning, and we'll talk more about Alzeimer's. So Alzeimer's, we talked, the reason it starts because of amyloid collection. Amyloid leads to tau collection. Tau leads to the neurodegeneration. And the genetics of it is that ApoE gene, and if there are 4 and 4 alleles, tend to have higher chance of getting dementia compared to people with ApoE 2 and 2 or 3 and 3. So that's the importance of that. The Lewy body dementia we talked about has potential to get the alpha synucleinopathy. Currently, the way I detect alpha synucleinopathy, I don't know it's done here, is through skin biopsy. So I do skin biopsies to check for alpha synucleinopathy, which is part of many other conditions like Parkinson's and corticobasal degeneration, but also for Lewy body, this becomes positive. And for vascular, the tau, both total tau and p tau, is elevated. And then frontotemporal goes depending on the type of frontotemporal tau or PTD43. Currently, not yet able to detect in plasma the TTV43, but that's going to happen soon also. So lot of good positive movement about early detection through biomarkers. And the reason for that is that we now have, at least in US and in Japan and Korea, approved the treatment for anti-amyloid, the disease modifying. We'll talk during the panel. I'll give my experience about my patients who are on anti-amyloid therapies. So thank you.
I request Dr. Madhvi also to come on the panel. Madhvi here. Any questions?
Thank you, sir, for this amazing talk. So we can start with questions from the audience first. We have our senior residents and our research staff, all are present. So, yes, Dr. Prabhakar. Dr. Prabhakar is from anatomy department. He's a scientist.
Sir, different biomarker in different timelines. So my question is whether it is having a relevance in terms of how it works with the different stage of time. That means Alzeimer's, whatever different stage of Alzeimer's. So how whether the patterns of these biomarkers are having the similar or something kind of different. First, second question is that the biomarker is how much is you can say because it may have a difference in terms of population heterogeneity or different parameters. So in terms of population variation, heterogeneity, and other parameters, how you can say biomarker is reliable in terms of because they may have a lot of variations and also may vary in terms of means we take a matrix and whether we are taking a CSF or plasma or serum. So definitely we are going to variation. So how we can control this?
Okay, so if I hear the question, and might have to repeat the question, but question is about the reliability of the biomarkers.
How we are having a different with the different stages of
So let me yeah, good question. So this graph, this chart, this biomarker applies only to Alzheimer's pathway, Alzheimer's disease. Does not apply to Lewy body, frontotemporal, or other dementias. And in the different stages, this is very on the earlier. So by the time somebody has got MCI, very likely, hopefully, they'll have only amyloid positive, and tau will be hopefully negative. But by the time more severe dementia happens, it's going to be A positive, T positive, and N positive. That there's going to be significant neurodegeneration also. Does it answer your question? So it's going to be amyloid positive in a significant amount, and very little will come out in the CSF, very high amount of tau and p tau and total tau, and neurodegeneration also. Thank you.
Any questions?
I just wanted to know, I'm Dr. Reema Dada, and we started the work on the impact of yoga in Alzheimer's disease in the last 6 months. I just wanted to know in which of these stages would any of these therapies be most beneficial?
Oh, a great question. So I feel if I was to advise or do prevention, as we know earlier the better. But if we were to do MCI, would be the right time. Mild cognitive impairment would be the right stage to apply all our knowledge of prevention, because MCI is the stage when there are biomarkers, but not, hopefully not neurodegeneration too much, or too much of tau, but that's the time reversal can happen. So mild cognitive impairment is where there's cognitive decline, but not loss of independence, meaning I can, as youngsters, we can do multitasking. So I can listen to some news, read my book, talk to somebody, do my cooking, but still able to function. With MCI, the multitasking goes down. The capacity to do that task needs more energy. So I can still drive and go from here to the airport, but might take me more time to remember, might have to use GPS more, might have to take a wrong turn. So that is a time where MCI is the actual changes can happen. And the changes are not short term, where the neurogenesis, the synaptogenesis will happen.
Right, thank you so much. And I would just like to add, though we've not got the result, we're still analyzing and still collecting samples. But I would just like to add, since you mentioned BDNF and various factors which are promoting neuroplasticity, earlier studies on MDD in our lab have actually shown an increase in the various factors promoting neuroplasticity. And in addition to that, various antioxidants like melatonin, which are found in the mitochondria, also showing an increase post practice of yoga. So I'm very hopeful that our results will show a positive impact on these cases.
Thank you. So those of you who have not hear the term BDNF, brain derived neurotropic factor, that increases when we do some form of meaningful physical activity, whether walking a lot or jogging or running or swimming or biking or yoga. The big muscles of body, the thigh muscles usually tends to secrete that, which goes into the circulation, and the brain derived neurotropic factor stimulates the neurogenesis. So no, I agree. I think that changes will happen.
Yeah, and another interesting thing, sorry, just a little deviating from this. Similarly, we worked on rheumatoid arthritis in cases with a positive family history. And just like you mentioned, there was only these genes mutations, or there could be, overexpression or underexpression of certain genes. So we also found in those cases which had a positive family history, in which we were thinking yoga would really have no impact, we found epigenetic changes. So genes which were detrimental to the function, we found they were getting, hypermethylated or silenced. And so we could again see the impact of yoga on those cases. So if there's a lot of chance that even if they do have a genetic basis due to epigenetic alteration, yoga would show a change.
Oh no, thank you. These are real. These are not just hopes. Again, the epigenetics, the cognitive research, the neuroplasticity. This is all real. This is all well proven, both in labs and in humans.
Hello. First of all, thank you for calling 60 years old as young. It is very encouraging. The question that I have is, some years, 2 years back, I reviewed the literature. Stressful life events and chronic stress used to be a major factor for onset of Alzeimer's and MCI. But in your slide, in the Lancet study, I couldn't see it.
So the great question. The question is about the stress, but I'll add a couple of other things also. So as you can see, the sleep is not there also. So quite many factors we feel, and I strongly feel, should have and have connection, are not in the Lancet study, because Lancet try to make it a very pure evidence-based, review-based articles, and sleep has now coming up, stress is coming up, but not, unfortunately, not enough evidence-based significant articles on that topic. So, but I agree, the stress has connection, because stress releases the steroids, the cortisone, and causes the PTSD and hippocampal narrowing. That's been seen. I've seen patients who are war veterans, and they would have the hippocampal sclerosis and thinning of the hippocampi. So I agree with you. Stress can be, but hard to give quantification. What is stress and how much to? And sleep. Sleep, I agree. I think Dr. Tripathi, Manjari Tripathi talks about sleep. The sleep I feel even stronger. Missing a night of sleep can increase. One small study showed missing one night of even sleep. Sorry for the medical students and the residents, that 30% of amyloid deposition in the brain increases. So there's a strong connection between sleep also. Thank you. One sec. Yeah, after just one sec.
Yes, I wanted to know about the neurocognitive rehabilitation, a single domain rehabilitation versus a multitasking. Question number one is which one works better? Second thing I want to know is that when you're talking about MCI and the rehabilitation at the MCI level, what I'm interested to know is would you call it reversal or would you be calling it delayed?
Good question. Let's start with the both, but the first one. So the studies after studies have shown that just doing one cognitive reversal will not globalize. Meaning, if I was to do just crossword puzzles all 8 hours a day, I get better at doing crossword puzzles. There's a word for that, cruci-verification. But that doesn't mean I'm going to remembering better. So it has to be global rehabilitation with as many different things one can add. And the reverse, it's not, I don't think it's a temporary pause. If it's done properly, the physical exercise, the yoga, the BDNF, that's a permanent neurogenesis. If the rest of the lifestyle is change also. So if I'm taking, and then we don't have time to talk, but if I'm taking a lot of anticholinergic medications, Benadryl, diphenhydramine, and if I do some reversal, then it's pausing and then that will come back.
What I meant about the single task is, of course, there will be multiple single tasks. When I'm talking about multitasking, I'm talking about switching between tasks. I'm talking about preventive.
That's actually, I just read an article from New York Times that actual brain doesn't use the brain. For brain, the multitasking is not real. We have to do one task at a time. So the multitasking, I would say the monotask is a better way to remember things rather than multitasking. If I'm reading my book, medical journal, and listening to music and thinking of something else, the brain will not focus. The encoding doesn't happen. So the encoding, as you know, we'll learn something, new term, let's say lecanemab or Leqembi as a term, but for brain to remember has to convert into encoding. And for that, it has to be monotasking. Otherwise, there's a task energy. The brain has to spend a lot of extra energy to make that one part remember. I feel that the question about by doing these 12 factors or yoga and better sleep, are we just slowing down for short term or reversal? I'm convinced it's a reversal if it's done meaningful long term way.
Namaskar. I'm Ashwini Kumar. I am in the social network. Actually, I was a caregiver for dementia patient, my mother-in-law, and I saw the real change in her routine when we used to take her for daycare, where activities were there, and then she used to herself say, "It appears as if I'm going to school." That was the change. Second thing, in COVID, lot of socialization has happened through Zoom and all that. We started joining laughing yoga, laughing yoga, because in yoga you have to do in proper rhythm and proper demonstration. Otherwise, it may have some side effects or something. But laughing yoga, nothing. You simply laugh, laugh, and laugh. And there also, chanting is there, clapping is there, dancing is there, some breathing exercises are there, and it goes very well.
No, agreed. The laughing yoga, I read about it. I have not practiced myself too much, but there is a science behind laughing yoga with the belly breathing and the belly moving. I feel that works. I agree. So,
Thank you.
thank you.
We can go on the panel discussion.
Yeah, sure.
You can sit. There's a mic here itself, so you can speak.
So, as you provided an overview, sir, we have the imaging modalities, we have CSF biomarkers, and now we have plasma biomarkers, which are upcoming. In an ideal setting, how do you decide which modality to choose, considering the age of onset in a particular case and considering the stage at which they present?
So, yeah, great point. With all these three areas of biomarker, just to remind, some form of neuroimaging, which is either most commonly structural, where we get either MRI or CAT scan, then becomes the functional, the FDG PET scan, or now the metabolic, the amyloid or the tau version of it. So that being one, the second being the lumbar puncture, checking for amyloid and tau and neurodegeneration. And then the plasma biomarker. I feel plasma would be the ideal in any situation, whether it's the Western US or India, because one, the amyloid, the PET scans are not easy. One, that's one. They are expensive. The lumbar puncture is a procedure, painful. A lot of patients don't want it. Plasma, we are all used to getting our blood drawn. So plasma would be the ideal as the technology gets better and the sensitivity of plasma gets better. Currently, it's if amyloid and tau PET were the gold standard, LP comes to the next close. The CSF is the closest, and the plasma is currently not there. 85, 87% sensitivity. But as sensitivity gets better, I feel that will be the ideal.
And Dr. Manjari, what would be the appropriate resource for our setting? We don't have amyloid PET, and I think CSF biomarkers are also not available in multiple places.
First is we have to know about the norms probably for our population. Like what are these values at the age of 50? What are the values at 55, 60, 65, 70? We generally, we know, whatever science has described for the Indian population is that we age earlier. So, what would be young, say in the Western world, would be older in, India. So we have to have what is the normal CSF values for a person who's normal in cognition versus MCI versus dementia first. What is the normal amyloid distribution as we age? Because we know amyloid is deposited even in normal people who would never develop dementia. We know that. So really first is to set the norms for our population, because if we are going to do it, say the 60-year-old, and we know the 60-year-old Indian is a little older than a 60-year-old American, we'll probably end up getting very high values and classifying them as having dementia or, precursor to developing dementia. So I think the first step is to establish norms for our population. For us, it would be more practical to have a test which can be given to the masses and which is inexpensive and also accessible. So, in my practical journey of almost 20 years of experience with dementia patients, almost 30 to 40% of them you are not able to get CSF because of the calcified ligaments. So, you do a painful procedure and you poke the patient multiple times and CSF doesn't happen. Many of them are also not hydrated well. So that means you have to give them an IV fluid and hydrate them well before you even attempt lumbar puncture in a 70-year-old and get a good, fluid. But saying so, knowing that amyloid PET is going to be very expensive for the common masses, the CSF would be a relatively less expensive investigation. And of course, if we can increase the specificity as well as the sensitivity of the plasma markers, that would also be very good. So as of now, I think CSF would be the best way to go. And if we can get inexpensive PETs, then that would be also good, and the plasma markers. But essentially, basically, you would have to have norms for that.
So continuing with
That's actually a great point, and just to a couple of comments. I was at the Public Health Foundation of India (PHFI), and they mentioned the same thing. That unfortunately, we Indians age 10 years younger than the Western because of multiple reasons, but one being that the social determinants of health and our uncontrolled vascular. So that's a good.
So, continuing with this point regarding the norms for our setting, do you have, sir, any experience with minority populations in USA?
So that's a wonderful.
I just have a quick curious question. Is the Indian community considered minority there? Or?
When we talk about minority, at least in the US, the minority currently happens to be the African American, which is about 11% of the population, and Hispanic or Latino, which are mainly coming from the central.
Indians are not minority.
And Indians are not big enough to be part of minority when we talk about minority. Meaning, if I was to focus, which I do focus on minority and dementia, Asians come in as a broad group and not Indians. What you mentioned are it applies to blacks and Hispanics in US also, meaning the biomarkers what are done unfortunately are more for Caucasian white people rather than the minority. And actually, I asked that question at the international conference in Amsterdam last time. Even the research I'll talk about, Lacambi, that's mainly only 3% were black, and rest were white and Latino. So even that will what we apply to minority would be different than compared to Caucasian.
So, our nuclear medicine department has been doing a lot of work with FTG PET, Tau PET. So, I would request Dr. Madhvi to share her experience with the Tau PET imaging.
Thank you, Dr. Anu. So, we've been doing, as we know, FTG PET is more widely available than Tau PET, and Tau PET is like mostly research based right now in India. Only a few centers have the advantage of using it. The advantage I would say of Tau PET when I hear of poly CSF and plasma would be it's more objective. So you actually do have quantitation, but it's more easy to interpret the scans as positive and negative when it comes to interpreting. So we have done Tau in mild cognitive impairment, early AD, and we've shown that there is a difference in the topography which we see when we're doing imaging in these. So it's easy to differentiate between normals and when the cognitive impairment starts in early AD and AD. And we've also done some work with you where we've looked at the different types of dementias like frontotemporal and Alzeimer's and how the topography of Tau differs. And of course, having amyloid would be easier because at least using amyloid and Tau, we can with more certainty say that this is Alzeimer's. We do have difficulty sometimes in differentiating even when we're using FTG or using Tau also. So we're waiting for amyloid and that would complete the spectrum and then we would be able to do ATN classification when it comes to imaging.
So what is the limitation with the availability of amyloid?
Amyloid presently is not marketed in India and we are asking a few companies to give it to us, but probably the market is not so much that they're bringing it into India. But we have GE and we have another of our distributors who's working on getting amyloid for us. And of course, cost issues would also be there. But since we have research-based studies, and that's where we would be able to undertake these studies, taking these patients into research projects.
So we also have with us the president of the national chapter of ARDSI, Mrs. Renu Vora. So during the talk, Dr. Yogesh mentioned that people over there come forth for getting themselves tested and knowing their ATN status. So how easy or difficult do you feel it would be in the Indian setting to convince patients to come for an early diagnosis, considering your experience with working with patients in the community?
Yes, most of the people over here are not aware of it, all of them, or they think this as a part of normal, or they are, sort of the people hide about their disease. And also, they're terrified. So this is a very challenging, process for us to convince them to go for early diagnosis. So this is the prime reason Alzheimer's Related Disorder Society of India conducts dementia awareness programs in senior citizen forums, schools, colleges, clubs, RWAs, as well as in communities, centers. So there we educate the people to recognize the early warning signs of this disease, and as well as tell them that help is available with us and we are ready to support them and provide them with more, support like memory clinic, which we send them to AIIMS and all that, to convince them to go for diagnosis. Then also we also give focus on the treatment of Alzheimer's, which is typically most effective in the early stages, as the doctors have said. And this includes, of course, medication, lifestyle changes, as we've already discussed, and also some alternative therapies like yoga, meditation, yoga nidra. We also tell them that these interventions may delay the progression of the disease, but now, as Dr. Shah said, we can even sort of say that they may even reverse this disease if we go for early diagnosis. And besides that, we make them aware that support, care, counseling, daycare, and respite services are available with ARDSI, making it easier for the patient as well as the family members to live the best possible life with Alzheimer's. Sorry.
There are some questions on the live chat box. So one of the questions is there any link of cannabis in preventing dementia? It seems to be a relevant thing.
I did expect this question coming in. Is it legal in India?
It's not, it's not legal, but bhang is legal. And Banaras, you find a lot of bhang. Government dispensary.
How far is Banaras from Delhi? I need to go. Can I go in one night and come back?
I can get
2 hours by car. So it's not legal, and we do have now the availability of cannabidiol for epilepsy management, but we do not have tetrahydro THC compound. So we do have cannabidiol.
So answer, I don't have clear answer on the use of cannabis in memory or dementia. It's a very wide topic. People do feel relaxed sometimes after consumption, and because of that, they feel memory gets better. But long term, as we know, it's not enough studies on long term consequences of that on dementia or even acetylcholine. So I don't know the answer long term. Short term, yeah, some people might feel better. My worry long term, as I touch on the topic, is the chemical acetylcholine. That's what we need to form short term memories. And by chemical, there are lots of chemicals which can deplete that acetylcholine. So I would worry about it to commit say yes.
So there are some imaging studies with long-term use of cannabis. They found gradual atrophy in particular areas of the brain. So long-term use of just general cannabis has been associated with neuronal loss and atrophy. So it's not probably going to help. There's another question here as to by Mrs. Reva Puri, who's asking if a person feels that they have memory impairment, what are the tests which can be done to confirm the same, and how frequently, and how many times would you have to do these? So it's more of a practical question than.
So in the and I'll let if you want to So I would say if somebody has concern, either they or the family members have concern, the best thing is to get at least simple cognitive paper and pencil screening till we have the biomarkers available. Meaning paper and pencil that they get done in the cognitive memory in the clinics, but even without clinic, simple tool like mini cog people can fail or other tests called MMSC, MOOC, and many others. So I would say that that's one. First would be if the patient feeling themselves, that's one. If the caregivers are worried, that would be really meaningful. And going specifically to the cognitive clinic or to your regular doctors, primary care doctors, internists, family medicine team, to specifically talk about memory.
Brain MRI.
So the question is about can brain MRI pick up? Unfortunately, the MRI would not pick up all forms of dementia or Alzeimer's in all cases. Early. If it is advanced, then it will be obvious to everybody. We're talking about just early, especially MCI. It's going to be lagged by many years. Correct? Would you agree?
Yeah. MRI would not be very specific, and actually because there is brain atrophy, and unless it's like the hippocampal atrophy is more specific, but then that takes time to actually.
So to be several, it will almost be like 5 to 10 years before the trophy comes in. What the biomarkers are all about is before you can see there, the zero is the clinical manifestation, cognitive. So even 15 to 20 years before, if you can identify those people who are likely to get into cognitive clinical impairment, that would give you enough time to do various interventions, including the control of blood pressure, the sugars, the exercise, the smoking, the whatever cholesterol, good food, all those exercising, etc. So you could work on your more seriously on your lifestyle and preventive strategies. If you get that need space.
MRI may be used with reversible.
Yeah, of course, MRI has to be done to rule out the
So by reversible causes, what we mean is that there's a condition called normopression hydrocephalus. Hopefully, if it is caught early and if shunt is done early, that can slow down or reverse. But the other reverse, it is an obvious tumor affecting the hip. So those are the very few reversible causes. But MRI by itself would not be, because the other thing is we all have different our brain at different levels. And my hippocampi is a score called MTA score, video temporal atrophy score. If my score is let's say 2, doesn't mean that I got memory problem. I have to compare my MTA with my own MTA in 6 months, 9 months. That becomes the issue.
So, one important question about your experience with anti-amyloid therapies.
Yeah, your anti-amyloid.
Their cost effectiveness,
That's
the
what is
clinical evidence.
Yes,
Yeah.
yes. Many patients are asking us now. We get patients who ask us, there's a new drug for Alzheimer's in the US. Can we have it here? So mostly they're talking about lecanemab, and unfortunately, it's not yet available in India or marketed in India. But you would have had experience in using the drug and following up these patients.
No, that's actually one of the main reason I came back to the clinic. So what's happened, as we talked about, there's a amyloid, and there are now amyloid plaque, and because of that, there's a anti-amyloid therapy available. So let me, if I can show you maybe a slide or two on that topic, and then I'll talk more about my own experience and my patient's experience on that field. I'll show you a couple of slides, and then we'll talk about. So this is a graph. There are in US there is a one now approved by the FDA, by the government, the CMS, which is our paying agency, pays for this treatment of anti-amyloid and Leqembi. So Leqembi, what it does is it binds to it's a monoclonal antibody, and that means that it binds to the amyloid plaque in the brain and then dissolves it or takes it away, and because of that the actual amyloid amount goes down. So what this graph is showing is three things. It's showing the Leqembi, in the treatment part, which is the part going down. The people who are in the Leqembi placebo did not receive actual treatment, remains flat, and on the other side, and Dr. Tripathi can see that placebo and Leqembi treatment group, the one in the beginning of the placebo and the bottom of the treatment group, the amount of amyloid goes down significantly by 71%. So after 18 months, actually it started even 12 months, the actual amount of amyloid plaque goes down by 71%, and it comes down to normal. So normal range for amyloid is considered as 30 centiloid. So the range is from 30 to 100, so 0 to 100. But at under 30, that is considered as a normal for people. And in 71%, in significant number of cases, the actual amyloid came down. So what the patients I have are luckily very early, mild cognitive impaired. I have 6 patients currently in the treatment, and there are 5 to 6 waiting. When I go back, I'll start. It's not a drug which is taken lightly, meaning it's given IV over 18 months, twice a week, twice a month, IV injections. And then initially it causes side effects. Side effects are it causes some transfusion reaction, just like chemotherapy for cancer. It can cause fever, chills, and others. But most of them, 70%, happen during the first transfusion and gets better. So if it doesn't happen first time, it doesn't less likely to happen. The other major issue, that's why FDA is very careful about it, is something called ARIA, ARIA, amyloid-related imaging abnormalities, ARIA, ARIA, and that is happens because as this anti-amyloid is working, it causes some bleeding. So there's ARIA H and there's ARIA E, which is because of swelling. My protein is coming out, it's like scab on the skin. If I scratch that off, there's potential to some bleed, potential to some swelling. Same thing happens with anti-amyloid. ARIA can happen in about roughly 30% of patients, and happens mainly early on. So by the 7th transfusion, it's 4 to 5 months that happens. So what we are supposed to do, requirement is to have a baseline MRI and then have a MRI after the 4th infusion, after the 6th infusion, and after the 13th infusion. That has to be done. And if ARIA happens, and there are criteria for ARIA happens, the infusion has to be stopped. So the baseline is those who are interested in radio MRI. The baseline, I cannot give a Leqembi if there is a more than 1 centimeter of hemorrhage, if there are micro hemosidrosis, if there is a vasogenic edema, then it's not allowed.
So how many of your patients which you used it was the ARIA associated with the clinical, symptom? Was it subclinical, or did it produce any, say, weakness or hemiparesis or headaches and vomiting, if it was the E or the H, or was it just picked up in the imaging?
So luckily and I'll talk about both research and in my experience, luckily in my own patient group, there's no ARIA. In the research part, the most ARIAs, only 0.7% of ARIAs were serious, and only about 6 to 7% of ARIA were symptomatic. So most ARIAs are asymptomatic, picked up on MRI only. And the symptoms were all the neurology, what you mentioned. They can have simple as nausea or feeling uncomfortable, gait change, dizziness, headache, and of course, serious would be actual enough hemorrhage to have stroke or epileptic features.
Sir, what clinical improvement you were able to see in these patients?
So that's a great question, and that's where the actual money comes. That yeah, we can remove the plaque, and then I'm showing this slide to show you why and how the anti-amyloid therapy works. So as you can see over here, the amyloid beta starts. Then if the lifestyle, I think that's why the prevention is so important, because everybody in this audience, we all have amyloid, APP. It's a long 720 amyloid protein. And unfortunately, in people with Alzeimer's, it breaks down into 42 and 40, and it starts collecting. So oligomer happens and protofibrils happen, and then those are soluble. But if that process still continues, then the insoluble, the fibril happens, which ultimately leads to the plaque. So the reason for talking about prevention, the yoga or whatever method we use is there's a long gap between amyloid getting formed in the protofibril and becoming the plaque. So what the question is, if I'm taking this anti-amyloid medicine and removing the plaque by 71% and causing what am I clinically seeing? The clinical things, two things happened, which was measured by a scale called CDR, sum of boxes. It's a research tool. I don't know, we all use it. But, so there are two main areas of CDR, sum of boxes. One is memory component. Second is functional component. Memory meaning how's my memory, judgment, orientation, and then functionality is how's my community affairs, my personal affairs, and my personal care. So those six and goes over 18 points, 0 to 18. What it showed is that Leqembi slows down this progression by 27%. And by slowing down, what it meant in real life is that person can remain active, can do more functionality for around 6 extra months. And within that 18 months, if they add, what I do is all my patients have to have some form of prevention now added to their life. Without that, I don't give Leqembi. So you have, if you add prevention, if you add the oral treatments, the donepezil and Namenda or memantine, and then if you add Leqembi, I feel that's more significant.
And can Leqembi be used in patients who don't have an amnestic presentation?
Since the question is amnestic presentation, meaning the amnestic, and so MCI can be either amnestic, meaning amyloid pathway, or non-amnestic, meaning non-amyloid pathway. Since it's working on amyloid, Leqembi, lecanemab, or similar has to be given for amnestic pathway only. It's not meant for non-amyloid pathway. It cannot be given for early frontotemporal dementia, cannot be given for even mixed dementia or vascular dementia. It cannot be given.
For the other presentations, like visual presentation of AD or behavioral presentation of AD.
So the question is about what about the different types of AD presentation, as you might have heard, the posterior cortical atrophy or visual type, and other front type of, yes, if it's still Alzheimer pathology, amyloid or pathology, then it will work. Actually, the sooner we give in amyloid pathology without the tau formation, it will work better.
So I think we've discussed extensively, and when Anu gives her first patient Leqembi, we will definitely get in touch with you because of your experience.
I'll come here in person. I'll fly just for that.
So she's trying for some of the patients. So I think we've had a very fruitful, your talk has been really great and discussion has been great. I request all the residents to stay back. We'll have a group photograph. But before that, there are some present duties. I request Renuji, you would have to do the honors of thanking our speaker who's come all the way from the US. And we look forward to your continuous guidance, particularly with what happens in the plasma biomarker realm, Dr. Shah. So thank you so much. And
No, thank you all. This is very meaningful. Just to come and talk and listen. And I like to keep in contact about BDNF and yoga and a lot of other, a lot of good things are happening here.
yeah.
I'm very proud to be here. Thank you.
So I request Renuji to kindly honor the speaker and vote of thanks. And vote of thanks.
Esteemed participants and guests, on behalf of Alzheimer's Related Disorder Society of India, we extend our sincere appreciation to the Department of Neurology at AIIMS for meticulously orchestrating this symposium. It has provided a platform for experts, researchers, and practitioners in neurology to convene and explore the latest advancement, challenges, and future directions concerning the utilization of anti-amyloid biomarkers in early Alzheimer's detection. We are deeply grateful to Dr. Yogesh Shah for generously sharing his expertise and insights, which have greatly enriched our discussion and provided invaluable perspectives on the use of anti-amyloid biomarkers in early Alzheimer's detection. Your unwaveringly dedication to advancing research in this field is truly commendable, and we extend our heartfelt gratitude for your significant contribution. We would also like to express our gratitude to the esteemed panelists, Dr. Manjari Tripathi, Head of Neurology, Dr. Anu Gupta, Assistant Professor of Neurology, and Professor Madhvi Tripathi from Nuclear Medicine of AIIMS for their invaluable contribution to the panel discussion and exchange of ideas. Their insights undoubtedly enhance the experience of all the attendees. To all the participants, we extend our heartfelt thanks for your active engagement, thoughtful questions, and as we draw this symposium to the close, let us carry forward knowledge, insight, and connections here today to continue our collective efforts in advancing research and improving outcomes for individuals affected by Alzheimer's disease. Once again, thank you for your participation and unwavering support. We eagerly anticipate future collaborations and continued progress in this field. Thank you.
Renuji,
Oh, wow. Oh, yeah, I'm there. Oh, thank you. I need to take pictures of it. Oh, thank you. Wow. This is special. Thank you. I'm going to come back. Do I get, if I come back, do I get the same thing again? No.
you can all assemble for a group photo. Dr. Deepti? That's we also with cohort study. In and around by population. So those are the. Jaldi आओ